Hi everyone, I'm Dr. Nitin Sobal. This is a webinar which has been sponsored by uh, the Lilac team. I'm grateful that they're doing some academic activity in in these days of COVID-19, where we are all uh, resting at home. So today, what I'm going to talk about is the fetus as a patient. Now, we have to understand that the fetus is a patient with its own rights, and we'll come to this point a little later, which means that just like the patients otherwise have the rights, or just like when we, for example, if there's a problem with the fetus, we normally counsel the patients about the problem. We might work out some sort of options for treatment or management, etc. But at that time, obviously, we cannot take the fetus into account as such, or we can't talk with the patient. But remember that the fetus has its own rights, and therefore, later on, maybe when the baby is becomes a man or becomes a woman at 18 years or 20 years, and if you have taken a wrong decision, and if you are alive that time, maybe the fetus, that particular person can sue you also. So just remember this whenever you take any decisions as far as a fetus is concerned. Now, we should also remember that we started looking at the fetus as a patient when we had this first book written by Harrison way back in 90s, The Unborn Patient. This is the first time we realized that a fetus is actually a patient. And this is a book on prenatal diagnosis and treatment. This was an eye opener, at least for me and maybe several people. But over the years now, of course, we have new editions. And now we have a special society for prenatal diagnosis therapy. We have ISWAP, so many other societies. So we are more aware of what's happening around us. But at least for me, this book was first like sort of a eye opener to look at the patient, fetus as a patient. And there is a very famous video which has been popularly circulated everywhere, where we have a fetus during the surgery for meningomyelocele, open surgery for meningomyelocele. The fetus removed its hand from the uterus and caught hold of the surgeon's finger, which is a very very emotional thing. And this, of course, is very popular and video which has been there for quite some time. Now, in our own sort of background or mythology, we know the story of Abhimanyu, who learned to get into the Chakravyu when Arjun spoke about entering the Chakravyu as Subhadra was sort of about to sleep. So he had the part how to enter the Chakravyu, but before Arjun could explain how to come out of it, he Subhadra felt asleep, and then we know very well that Abhimanyu was not able to come out of that dreadful circle, and the end was therefore quite obvious. So, in our own mythology, we have stories of fetus acting intelligently. Now, if you look at literature, the recent literature, in fact, there are a lot of stories about, there are a lot of findings about fetus. For example, it is now very well known that the fetus can, by 9 weeks, developing fetus can have hiccups, can react to loud noises. By the end of second trimester, it can hear. Just like adults, the fetus experiences rapid eye movements, that is the sleep of dreams. The fetus also enjoys his mother's meals and picks up the food taste of culture in the womb. And among other mental feats, the fetus can distinguish with the voice of mom from that of stranger and responds to a familiar story read to it. Even the premature baby is aware, feels, responds, and adapts to its own environment. So the fetus is much more intelligent than what we thought all these years. So in my own home, like we have sort of we realized that when my grandson was in the womb, my daughter-in-law, who is a fish eater, he used to love fish, and he used to kick whenever she used to eat fish. And today, when he is 1 year old, he still enjoys fish. So maybe all these things are true. We don't know. So we do when we do a 3D or 4D, we do see some feti with their own activities. With these we see feti who are sleeping. This one is a thinker, maybe a future, president of India. This one is a very happy one, smiling always. This fetus is singing loud. from the lip movements, maybe we don't know what sort of a song she's singing, but continuously singing. This fetus is quite naughty, and the way it shows its tongue, it's quite obvious that it's up to some naughty tricks. And this one is an angry fetus, maybe like the movie Albert Pinto ko gussa kyun aata hai, something of that sort. But these are things which we see when we do 3D. This fetus is quite sad and crying. So each fetus has its own emotions, and we can probably see them when we do ultrasound on 3D and 4D. The fetus gets pain, and typically, like for example, when we are doing procedures like any fetal intervention, very often we see that the fetus tries to grab the needle uh, while when we are doing the procedure. And therefore, as a routine nowadays, very often if you're doing a longer procedure, like for example transfusion, we always give anesthesia to the fetus in the thigh so that the fetus lies still for quite some time. So we have two important scans which we are very familiar with. One is an NT scan, the other is a targeted scan. Uh, Both these scans are meant for various reasons. The NT, well, after the end of these scans, what we do pick up are fetal anomalies, which could be structural anomalies, or very often we pick up markers of chromosomal abnormalities. And along with biochemical tests like double marker or quadruple marker, we might have to do some diagnostic tests. So typically, for example, some of the diagnostic tests which are done routinely include, of course, amniocentesis, Korean Miller sampling, as well as fetal cord blood sampling, depending upon the situation. What is very important is that these markers, the biochemical markers as well as ultrasound markers, are just markers for potential chromosomal abnormalities. And therefore, if you see something like an NT, it means we have to evaluate further, but that doesn't mean that we should terminate the pregnancy. This is very, very important. So here, for example, we had a fetus with trisomy 21. Now, sometimes you come up with very interesting diagnosis or some diagnosis which you have not suspected. For example, here we had a cleft lip and a cleft palate, and we did a amniocentesis for this, and this turned out to have a mosaic loss of chromosome 4, some parts of chromosome 4, and this was reported by Chaitra as Wolff-Hirschhorn syndrome from Lilac Lab. And if you look at this particular syndrome, this babies have what is known as a Roman mask face like a Roman mask or a Roman soldier. And if you do a 3D reconstruction of this fetus, we also saw that this particular fetus also had a similar sort of a mask there. More commonly, we do tests for thalassemia, and typically, if the father and mother are both carriers, then or both are minors, then we always do a CBS nowadays as early as 12 weeks of gestation. So that's a CBS being done on a thalassemia minor, and unfortunately for this particular patients, the report showed that the baby was affected with thalassemia, and therefore they decided to terminate the pregnancy. But this we can now pick up very well. So in India, we know that there are certain sort of communities where this is very common, and we need to do this test on these patients. This is a very common problem which we encounter in day-to-day practice. This is a lady who came with her son, older son, who was mentally retarded, and she was already pregnant. She was almost about that time 8 weeks of gestation. And she said that this my son is mentally retarded. Now you tell me whether my fetus is mentally retarded. Now, this is a very difficult situation. Most of the times, the proband, this is known as the proband, has not been properly evaluated. And they do multiple tests, and because the tests become very costly, they sort of stop doing the tests in between. So here, fortunately, we had a proband. Very often, we don't have a proband in hand. We evaluated this proband thoroughly from our genetic team, and we found that this has mucopolysaccharidosis 3A. Now, once you know the diagnosis, then you know which gene to look at, and then we can do specific tests for that particular pregnancy. So, what we did in this case, of course, is we did a CVS again, and on the CVS, we analyzed this for that particular gene, and we saw that the reports were quite normal. So this is very important. So making a diagnosis in the proband is very, very important. And once you have a diagnosis in the proband, then can evaluate the present pregnancy. So this was another lady who came with this child, and this is of course progeria. So she came to us in the evening and said that this is my first child, and now I'm pregnant. Now, what we want to tell the clinicians as well as parents is that if you have a child who is affected, it is best to do gene analysis before you conceive, so that there are so many options which are available with us, including of course prenatal, pre-pregnancy genetic testing and all. So basically, it is very important to evaluate the proband before they conceive. Now, here, for example, we had this child with progeria, and she was already pregnant. And very honestly, when they came to us, we were not aware of what progeria is, but we went into details and we found out that basically in progeria there is a problem with one protein which is known as prelamin A, and there is a gene which controls this protein which is known as a gene LMNA. So basically, what we did is then evaluated the proband, and then once we actually isolated the gene in there, then we did a prenatal diagnosis for the present pregnancy. And fortunately, there was no mutation in the present fetus. The fetus was quite normal, and postnatally, of course, this was concerned, and this baby is quite normal. Very unfortunately, this child, who was a very nice child, he's only about 13 years old, looked very old, very sweet child otherwise, and he used to come to us very often because we did all the tests for the mother. And very unfortunately, this child succumbed to dehydration maybe 1 year after the next child was born. So that was very unfortunate. Sometimes we do diagnostic tests to plan the mode of delivery. And here, for example, we had a doctor with us who was diagnosed to have an interrupted aortic arch later in the pregnancy, almost at 32 weeks. But she wanted to evaluate further because we know that aortic arch anomalies are associated with genetic abnormalities. So we did a cordocentesis for this particular mother, and we took the blood from the cord, and this turned out to be a Cri-du-Chat syndrome. So in a Cri-du-Chat syndrome, this is known as a cry of the cat. And what happens here is that there is a partial deletion of chromosome 5p. So these children don't have a very good prognosis. They can have an abnormal faces, and this is how they cry. If you can hear that, they have a cry which resembles that of a cat. And rightly so, when this child was born, it did a cry, which was like the cat. But unfortunately, the baby could not survive, and the baby succumbed to at birth itself. As far as treatment options are concerned, there are few conditions which we treat successfully nowadays. I think a good number of people do that. And one such is, of course, treating fetal anemia. Now, this is a lady who had lost three children to intrauterine fetal deaths, and her blood group was obvious Rh negative. The husband was positive, and because she was living in a village place, there was no access to anything, and all she landed was IUFDs. So when she came to us, she was already 20 weeks. There was already hydrops with hyperamnios. The middle cerebral artery showed high velocities, almost about 90. So we know that we diagnose anemia by looking at MCA.PSV, and then we put it in mom and find out whether if the mom is typically above 1.5, then we know that this fetus requires transfusion. So rather than waste any time, we proceeded with transfusion. So that's the anesthesia being given into the fetal thigh, and then of course we put a needle into the umbilical vein, either at the placental end or at the fetal end, and we remove some blood for evaluation. We send it to the lab, which should be in house. And before you get the report, we already start the transfusion, and we now have charts and softwares whereby we know what is the amount to be transfused of what we transfuse, of course, uh, packed cells, O negative, which are radiated and tested for all infections, etc. So typically, we might have to sometimes transfuse anything between 60 or 80 ml in day-to-day practice. But what happens is immediately after transfusion, the middle cerebral artery velocity drops to sometimes normal, and that's a good now sort of guideline for us to look whether the fetus is becoming anemic again or no. So of course, because we started transfusions at a very early stage, normally you'll end up doing transfusions at 28, 29, 30 weeks of gestation. Here we have to start a little early. and therefore we had to give almost like three transfusions. But at the end of that, the baby was born at around 36 weeks. And the hemoglobin was very good at birth. That is what we want to achieve. At birth itself, the hemoglobin should be good, and this child has done subsequently very well. Another treatment which is very successful in utero is of course fetal hypothyroidism. So this is a lady who herself was hyperthyroid, and she was taking neomercazole and preconception. She was taking things. And she had also taken PTU, and basically she was uncontrolled in the sense that she never went to the doctor properly. She probably never told the gynecologist a proper history. And when she came at 26 weeks to us, there was hydramnios. The fetal thyroid was grossly enlarged. It was extremely vascular, and therefore we thought, of course, that there is some thyroid problem in this fetus. So we have measurements for thyroid, charts which tell us whether the thyroid is enlarged or no. And once we were convinced that the thyroid is enlarged, we wanted to look at a thyroid function of the fetus. So there are two options. We can do a chordocentesis, or those days we used to do amniocentesis, and we looked at the fetal TSH values, which were very high, telling us that the fetus was hypothyroid. And therefore we went on to treat the fetus with levothyroxine. So that's the needle coming into the amniotic cavity, and that's the thyroxine injection being given. There is a dose of levothyroxine for the per fetal weight. And typically in this condition, we had to do three injections. It is difficult to get thyroxine, but we could manage to get it. And post injection, her TSH values from the amniotic fluid dropped. As I said, nowadays we do chordocentesis rather than do look at the amniotic fluid. And at 32 weeks, the LICA reduced, the size of the thyroid reduced, the vascularity reduced. And at about, because the LICA went on dropping at 34 or 35 weeks, we induced, and that's a baby with a with no thyroid swelling, totally euthyroid, and has done subsequently very well. In fact, this girl now comes to us very often on her birthday, and she's quite normal. So this is one situation where a certain cretin, she would have landed being a cretin if we had not treated in utero with thyroxine. So this is one area where in utero therapy is very, very successful. The other area where in utero therapy is successful is fetal arrhythmias, typically tachyarrhythmias, which are treated either with digoxin or fletamide. So here is an example. We had a ventricular rate of almost 263, an atrial rate of 263, rate about 250. She was hospitalized, of course. If you want to do digoxin, she has to be hospitalized. And rightly so, we could manage the rate and deliver at the right time. And subsequently, this child has done very well. Even bradycardias, we can give steroids, or we can give, depending upon the cause, we can treat it. We can keep a very close watch, deliver at the right time, and sometimes, of course, put a pacemaker at birth. Then there are some interventional procedures which we can do. Typically, here, for example, we had a fetus at 36 weeks with idiopathic pleural effusion, gross effusion. The lung was totally compressed, as you can see, collapsed totally. Now, if you deliver with this sort of a huge effusion, this child may not do well immediately at birth. So what we did is, of course, put a needle and tapped the entire fluid, and you can see that the lung has expanded. That's the tip of the needle still seen. And then we waited, and fortunately, this did not recur. Otherwise, we would put a shunt from the pleural cavity into the amniotic cavity, and this fetus again was delivered at 38 weeks, has done very, very well. CPAMs, large cystic adenoma and malformations, can be treated by aspiration or by putting shunts from the cyst into the amniotic cavity. So this is one example. This is a lady who at 29, 30 weeks had a huge CPAM, both macrocystic as well as microcystic, but majority being macrocystic. And normally after 26, 27 weeks, we see a gradual reduction in the size of CPAM. But in this case, the CPAM went on increasing. At 30, 31 weeks, it was very large. And moreover, there was no hydrops, fortunately. So we wanted to prevent hydrops, because once you have hydrops, then very often you can have a fetal intrauterine death. So what we did is put in needles in the large cysts, and aspirated large cysts. We removed almost about 20 ml of fluid. 20 ml of fluid in fetal lung is a huge amount. And rightly so, after aspiration, CVR dropped significantly. The mediastinal shift, which was there, also came down. and we again managed to take her up to 38 weeks, and she delivered later on. Unfortunately, this lesion was very large, and subsequently had to be excised, but otherwise the child has done well. If we had not done this, then we would have intrauterine hydrops, and as I said, that once you have an hydrops, the prognosis can be bad. Congenital diaphragmatic hernias are being treated not in our country, but elsewhere with tracheal plugs. And the funda is that if you plug the trachea, then the egress of the fluid from the lung is prevented. So the lungs get distended, and the lungs sort of push the diaphragm and the intestine into the abdomen cavity. The problem with diaphragmatic hernia, all of us know, is that the lungs become hypoplastic, and we want to prevent lung hypoplasia, and this seems to be a very good option. And just before that birth, of course, very often the plug is deflated, balloon is deflated, and the results seem to be very encouraging. Other shunts which are done include, of course, shunts for luto or lower urinary tract obstruction. Here it is very important to choose the case. Here, for example, we have a luto with bladder distended, posterior urethral wall dilated, but the kidney is already dysplastic. There is no liquor at all. Such a thing, in this particular situation, the prognosis will not be good, and therefore one has to be very careful when we select the patient. In this patient, there is fetus, there is a posterior which is dilated, gross bladder distension, kidneys are dilated, but the liquor is good. So we evaluated for chromosomal abnormalities. Then the next thing we very often do is look at the renal function by puncturing the fetal bladder, and then we need to repeat this again after 48 hours. So if you feel that the kidneys are doing well, then we can think of doing one of the divergent stents. Typically, we used to do psychoamniotic shunts, and these are now easily available. Of late, of course, we can also do cystoscopic laser ablation of the posterior valve. So this, of course, I have not done, but this is a clipping which Dr. Suresh has given to me. And here, as you can see, the posterior urethra is dilated, bladder distended, and he is going into the bladder, into the posterior urethra, and he fulgurated the valves. And this particular fetus or the child has done very well. Of course, there's a risk of developing a urinary fistula, but with proper technique and proper care, this can be prevented. As far as cardiac anomalies are concerned, two areas where interventions have been very successful, or rather one area where it has been very successful, is in utero aortic balloon valvoplasty. So typically we know that when there are critical aortic stenosis, very often the left ventricle fails. It goes into what is known as fibroelastosis. So here's a classical example where the left ventricle is huge, is very bright, very high velocities across the aortic valve. And this may not have a very good prognosis if nothing is done. So typically when we have aortic stenosis, there are grades of aortic stenosis. It can be mild, moderate, or severe. So typically we look at things like reversal of flow in aortic arch, left to right flow across foramen well, altered pattern on a mitral valve, and LV dysfunction. And if we feel that this candidate is potentially good for valvoplasty, then we do have Z scores which are taken. Typically, we have been following up some patients, and I am in touch with Dr. Nagesh Rao for this. He is the one who has been doing this successfully in India. And one of our patients, which was referred to him, he did a aortic valvotomy. So I'll just show you the clipping if it can run. So that's the left ventricle being punctured. This was done by Dr. Nagesh Rao. And that's a the needle going from the left ventricle into the aortic valve. And then we see a guide wire passing across the aortic valve, and finally the aortic valve being dilated. But patient selection is very, very important, number one. And this is a very, very extremely skillful technique, which of course can be done at few centers, but the results are very, very encouraging. Again, patient selection is very important. For example, we had one or two patients where I was worried, but he assured me that this is not a very severe stenosis, and this fetus is going to do very well. And subsequently, they have done very well. So he is an expert, and we can take advice from such people. Simpler procedures include amnio reductions and amnio infusions. Typically, if there's polyhydramnios and if you have no other tools, you're working in a small place, maybe to buy time, we can just reduce like a year. For example, we had a fetus with Bartter syndrome, gross polyhydramnios, the bladder distended. The fetus was continuously peeing inside the amniotic cavity. I don't have a video there. The kidneys were mildly dilated and showed quite a little echogenic. She had lost three babies to this. Again, she had come from a native town, so nothing was evaluated. But this is typical of Barters. So what we did is we did an evaluation. Of course, we proved it is Barters by amniocentesis, chordosynthesis, and then all we could do is do an amnio reduction. So we did serial amnio reductions. The baby was born at 32 weeks. That's the faces of the baby, and they have a lot of electrolyte imbalance at birth, and unfortunately, this baby succumbed. But we stored his blood for DNA analysis. We confirmed it is Barter's. We found out the gene mutation, and subsequently, when she became pregnant, we did antenatal tests, and she had a normal baby. Amnio infusions can be done for two reasons. One is to buy time. Typically, if it's idiopathic and you want to infuse amniotic fluid, so you can do amnio infusion. Or when you're suspecting that there could be the associated anomaly and you're not seeing fetal structures too well, you can do amnio infusion and look out for fetal structures. More commonly, of course, we do fetal reductions, and the idea here is to enhance the effects of pregnancy, at least have one or two normal embryos rather than have a premature delivery or abortion of all. So typically, if you have multiple pregnancies and if they are multichorionic, then reductions are very easy. Here, for example, we have one fetus which has acrania. So we selectively would target that fetus and inject potassium chloride so that the other fetus grows very well. So once your needle is in the heart, then we can see blood coming into the syringe and we inject potassium chloride. More commonly, here we do reductions whenever there are multiple pregnancies. As we know that once you have multiple pregnancies like triplets, quintuplets, quadruplets, then there is no place in the womb, and if you don't do anything, then in fact abortion, premature delivery is going it would be the norm. So here, for example, we had quintuplets and we reduced three and left behind two. Sometimes you have seven, you have to reduce five. We reduced five and left behind two. So that is the maximum we have done. But this is so that the other two healthy survive. This is a dichronic pregnancy and one fetus has skeletal dysplasia. This looks lethal. Now you can leave it alone because this baby is going to die after birth. But if you leave it alone, there can be a lot of hydramnios coming up at a later stage, and this can hamper the growth of the normal fetus. So we decided to put potassium chloride in this fetus who had skeletal dysplasia, and the mother continued with the pregnancy, and at birth you can see that's the fetus with skeletal dysplasia, and that's a normal baby, and she is now a beautiful girl, I think almost about now 8 years old, and she also comes and meets us very often. So what we did here is of course sacrifice this anomalous fetus so that we have one healthy sibling who has seen the light of the day. In monogenic twins, things are difficult. We cannot do reductions just like we do in multichorionic pregnancies, because if you have one fetus who with an IUD, uh, the other fetus could suffer because of so many problems like the normal fetus bleeding into the other one, etc. So we need to have a technique which can sort of occlude the cord suddenly, or we need to have techniques which can take care of anastomosis, because anastomosis is the area where there are problems. So in monogenic twins, we have problems like selective fetal growth restriction, TTTS, TRAP, twin embolization syndrome, and typically in monoclonic monoamniotic, we can have problems like conjointins, cord entanglement, and cord knots. So the a cardiac monster or trap is a common thing we see in day-to-day practice where one fetus is normal and the other is a cardiac. The problem here is that if this volume of this cardiac twin is becomes very large, then this can again hamper the growth of the normal fetus. And therefore, if once you see that this volume is increasing, then we need to reduce this fetus. But we can't do it with KCL, obviously. So over years, we have been trying various techniques. And one technique which was very successful for us was gel foam. And what we did is we put in a large needle so that we were into the umbilical cord, artery, and the vein together, and then we injected gel foam, and we had very good results, more than 60-70% success rate. And that's one of the babies which was born. That's an cardiac monster in the tray, and this was doing well. Nowadays, of course, what we do is a laser ablation. So here's one more trap with the trap baby being very huge as compared to the normal one. And so what we did is we put in a needle between the two vessels in the pelvis, and that's the needle going in, and then we put in a laser interstitial laser fiber and burnt this so that this cardiac fetus, the heart stopped, and subsequently, of course, the other baby delivered. We can also do laser ablations in monoclonal twins at an early stage as a part of reduction before the anastomosis in the placenta happens. But here again, this can be dicey, and we can end up losing the other one as well. TTTS is being treated nowadays by certain centers in India. Typically, what is done, of course, is laser ablation of the anastomotic side, and this is one such clipping of a laser ablation being done for TTTS, and that's a healthy baby born afterwards. More commonly, we see SFJR or selective fetal growth restriction. And this is, for example, after a TTTS laser ablation, we can see that the liquor in this may be improved. But these techniques are not very easy, and we need to keep a very close watch after the technique. More commonly, we see SFJR or selective fetal growth restriction in monoclonic amniotic twins. And here, for example, we had a type 2 SFJR with almost absent diastolic flow. This was at about 17 months. Yeah, this was around 20 weeks of gestation. So we decided to sacrifice one fetus after talking with the patients, and we did a cord coagulation of the fetus, which in this case was smaller. And subsequently, of course, we kept a very close watch on the pregnancy, and she delivered around 30 to 34 weeks of gestation, a healthy fetus. That's another example of a bipolar cautery being done in a selective FGR. This is one more pregnancy where again we have a selective fetal growth restriction, 90 to 20 weeks, absent diastolic flow. So again, stage 2. And here what we did is we did an RFA of the smaller fetus. That's an RFA needle going into the pelvis. And once you do that, then you need to keep a very close watch on the fetus which is surviving. Look out for the middle cerebral artery Doppler. Look out for any intracranial changes which could suggest hypoxia. Look out for the appearance of the intestines. Keep a close watch on the Doppler. And subsequently, you might also do an MR. So we pulled on this pregnancy. Everything went on well till 32 weeks, and she delivered. Fetal surgeries, of course, we don't do as of today, but as we saw earlier, meningomyelocele have been treated in utero, and there's a big series, of course, from US on that. What is very, very important is teamwork between everyone who is involved. We are very fortunate to be working with genetists like Dr. Chaitra from Lilac. We have other specialists. We have a pediatric cardiologist with us. We have a pediatric neurologist. We have a pediatric orthopedic surgeon. We have a pediatric surgeon in our team. So when we counsel the patient, depending upon what the issue is, we take help of these people. And it is only after explaining everything to the parents that we take a decision and whatever is best for the patient and the fetus. But remember, again, as I said, that the fetus has its own rights, and therefore, whatever decision we take today has to be good for the fetus and the child or the person who grows up later. So Indian feet are quite intelligent and they love cricket. And this is a lady who used to love cricket. And we saw that in utero also the people started giving decisions of umpiring decisions of what is happening on the pitch. So remember again that the fetus has its own rights, like human rights, and we need to be very careful about what we decide as far as fetal management is concerned. Thank you so much. So there is nothing on chat. I'll go to the. Questions. Yeah, I can't see any questions on the chat mode. So I think thank you so much. And maybe you can send a mail or something to me because I can't see the questions here. Thank you so much.
A very good evening to all of you. Very sorry for the interruption. Sorry, I had to leave due to an emergency. If you type out all your questions in the question box below, he's going to personally email and reply to all of you. So sorry for the inconvenience. Thank you for attending the webinar.